Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator in the NICU. And it is August, and in August we are kind of going back, right? It's the 1 year kind of anniversary of my page, of my YouTube page, and my Instagram page. And so we are doing big giveaways over on Instagram. So if you're not following me there, please jump over to Instagram. My handle is the same here on the slide at Houston we have and we are doing giveaways, and we're going to redo some of the slides that we initially did during my first Teach Me Tuesdays, because now there's a lot more of you and I've gotten a little bit better with my information and my recording. So today we are going to talk about that golden hour admission, the first 60 minutes of life for both our extremely low birth weight infants and our late preterm infants. So let's dive in. When we think about the golden hour, it's really important to remember that the technical definition of golden hour is the first 60 minutes of life. In some units, babies are delivered kind of far away from the NICU, and it takes time to get to the NICU, and maybe they're not actually getting their admission things done until maybe 20 minutes of life. But because of what we do in NRP and our resuscitation and our delayed cord clamping and heating the room and everything, the golden hour truly begins from when the baby is born. So in those first 60 minutes of life, we are really trying to achieve a lot of these goals so that we can improve the long-term outcomes for our babies. We want to make sure that we are maintaining normothermia, right? So during delayed cord clamping, if a baby qualifies for delayed cord clamping, meaning that they are vigorous, right, breathing or crying, has tone, and has a heart rate. That's what vigorous is, flashing back to our NRP. Then those babies are getting delayed cord clamping. And that minute of delayed cord clamping is actually a pretty important part of the golden hour. It's going to help with our blood volumes, our blood pressures, our blood sugars, all of those things. So that's important. But once they get on the bed, we want to have our pre-warm mattress. Then we want to get them even to the NICU, where we're going to continue focusing on our normothermia. We're going to begin our fluids. We're going to start antibiotics if needed. We're not going to start antibiotics on all babies because of antibiotic stewardship. We are going to do it for the maternal indications, but if they need them, we want to get those started within 60 minutes. We want to stabilize our blood pressure, making sure that we, on our extremely low birth weight infants, are treating judiciously with our fluids. We're not giving them too much because of the fluid going on our lungs and our PDA. In our older babies, our late preterm infants, making sure that we're treating symptomatic blood pressures. We want to know about our blood sugar, keeping that in a good range. Again, if we flash back to our total fluids that we reviewed recently, we don't want to keep increasing our total fluids for our blood sugar. Maybe we need to think about our DIR, meaning we need to increase our dextrose concentration in our fluids instead of our total fluids. And of course, our neuroprotection. So let's start with thermoregulation. In our extremely low birth weight infant, we want to prevent hypothermia at all costs. At the last bullet you see over here, for every degree below 36 degrees Celsius, the mortality increases by 28%. That's taken straight from the literature. It is so important that we focus on our thermoregulation. So for our smallest infants, we want to cover them with polyurethane, even something here like a poncho. Got a little poncho demo today. This is great. The baby can get zipped in here. You can use the Velcro to open up and place lines. This is a great tool, or you can just be using the cover. You want to make sure that when we get into the NICU, that we are starting that humidity and getting the top of the incubator closed within 60 minutes. And we also want to make sure that we are using warming mattresses. Not only do we want the mattress warm, but we want to make sure that if we're switching out and putting positioning devices in, whether that's just a nest that we are making with a blanket, we're using dandelion products, we're using a Z-Flow, whatever it is, that it is pre-warmed. So we're putting the baby on a pre-warmed mattress. Those late preterm infants have lots of contributing factors that are going to affect their temperature. In fact, some of our late-term infants come to the NICU only because they got cold on mom baby. And you know what happens with a cold baby? Their blood sugars are also going to drop. So they have decreased brown fat stores, decreased subcutaneous fat. They have an increased susceptibility to heat loss, which we're going to talk about a few of those. They cannot conserve their heat. We want to keep them skin to skin, get them skin to skin, keep them skin to skin. We can't always do that, especially if we're bringing them to the NICU. So we want to make sure we're using a radiant warmer for them during their admissions to keep them warm. Thermoregulation is the first thing we're talking about because it is so important, and it is something that you as the bedside nurse can easily control. Making sure we are on skin servo mode for our smallest babies, on skin servo mode for our late preterm infants during admission, making sure we get those wet linens out. Okay, this is an extra slide that's not on the Instagram page. We're just reviewing, right? Evaporation, convection, and conduction. All three of these are super important. And when we think about that late preterm infant, if they've been in mom baby, or maybe we delayed in getting them down to the NICU, maybe they did skin to skin and then we took them away from their mom, we swaddled them up, brought them down in a crib. And the unit I previously worked at, we did not bring babies down in cribs. We stopped doing that practice. Even if they were in a crib on mom baby, we transferred them in incubators because of the risk of hypothermia. So think about all of those things that are contributing to these babies. Obviously, this is also impactful for our extremely low birth weight infants. But when we think about those late preterm infants, they have more of these risks because we are maybe letting them be around mom more. We're admitting them in cribs. We don't put them on skin servo mode. We have hats on them. We haven't gotten their hair all the way dry. So thinking about that evaporation with the wet skin, thinking about convection where we're losing heat to the surrounding air, and then conduction when we put them on a cold surface. Next most important, of course, is respiratory. Our respiratory system is so important. When we think about that during the golden hour, we want to try to use non-invasive ventilation whenever we can for our extremely low birth weight infants. For giving them surfactant, if we need to do that, we could do it in a non-invasive way with a Lisa method where they do that's not named after me, I wish, the less invasive, or the in and out, or dose and release, whatever we're doing so that we don't keep them intubated. But for invasive ventilation, we want to use those low pressures or something like a jet to prevent barotrauma. We have lots of previous Teach Me Tuesdays about conventional versus high frequency ventilation and what that means, so refer back there. We want to make sure that we're judicious with our oxygen. We don't want to be giving them too much, but we want to keep them in a safe place. Watching our pH, not drawing too many blood gases. Remember, every time we're drawing those blood gases, we also can be affecting the blood flow throughout their body and what's going to their brain. And then using our gastric tube for decompression, I say on admission, you get that gastric tube in for a late preterm infant or an extremely low birth weight infant, so it's already in before your first x-ray. That should be one of your first goals. With our late preterm infants, we have to think to ourselves, are we having TTN, like transient tachypnea of the newborn, or are we in respiratory distress? Because the respiratory system, as we know, right, babies start producing surfactant around 22, 24 weeks, and they produce it their whole time in utero. So it's not a perfect system. Every baby doesn't produce it at the same rate. And it's one of our last systems to mature, right? We aren't using our lungs in utero. The placenta, my favorite organ, is doing that gas exchange for us. So when they come out, is this transient tachypnea where they're having a late transition? Maybe they have extra fluids on their lungs. So we're probably going to need to give them some CPAP, some oxygen, put them on their belly, help them with their ventilation ratios. For respiratory distress syndrome, more of we didn't have enough surfactant, our lungs are underdeveloped, we're probably going to need supplemental oxygen in addition to surfactant and probably some form of ventilation, whether that's non-invasive or invasive. Getting our respiratory system under control in that first 60 minutes is key because a lot of damage can be done in a short amount of time, and major swings in your pH are also not good for the risk of brain bleeds. Our total fluid goals and our blood pressure. So we went over total fluids recently. We talked about the importance of starting at fluids of around 60 to 80. On our extremely low birth weight infants, we're going to start with the central line insertion, probably an umbilical venous catheter and or a UAC. We're going to start D10 with protein in it, such as starter TPN or vanilla TPN, whatever your unit calls it. We used to say, oh, we just need to give them sugar, but over time, evidence tells us that getting protein started on the first day of life is key to improving long-term outcomes. We want to monitor their blood pressure and keep their MAP greater than their gestational age. If it's lower, We may start with a normal saline or an LR bolus of 10 mils per kilo over maybe 30 minutes. And that might be enough. That might be all the baby needs. If they need more, we're getting to this place where should we start some inotropes such as dopamine versus another bolus. And on our smallest infants, the risk of fluid overload is so high because fluid overload is putting extra pressure on their lungs that we may not be giving them more boluses. We also want to watch if we're having urine output. If the baby's not peeing, the inotropes may also give some kidney stimulant, and so to help with that. And then obviously watching their electrolytes over time. But at the beginning, those first 60 minutes, our goal really is to get those fluids started, to get D10 with some protein, or that's trophamine, amino acids, whatever you're adding in, and keeping our blood pressure in a stable area. On our late preterm infants, we may not start fluids on them. We may start with feeds. It could be a fluids versus feeds depending on if the baby's in respiratory distress or not. If fluids are started, we're probably going to have a PIV versus a central line. We may start lower at total fluids of 60 mils per kilo per day and then just using straight D10. If your baby is less than 1,800 grams, we will likely be starting that D10 with some protein in it. Also here, we're going to watch more for that symptomatic hypotension, not just looking at the map, but also what else is the baby doing? What is the capillary refill? What is the urine output? Because they tend to have that quick low dip in their blood pressure and then it comes up on their own. So instead of treating them, we want to watch for symptomatic blood pressures. Watch for their intake if they're taking feeds. Sometimes they are poor feeders, they have poor latch, which we'll talk about with our blood sugar. So we need to be sure that if we are on feeds, if they're on breastfeeding or formula feeds, that they're getting the appropriate amount that they need, which is also going to affect their blood sugar. On an extremely low birth weight infant, your normal range in that first hour, especially in the first 24 hours of your blood sugar, is going to be bigger. Because those babies are in stress, you may see higher blood sugars pushing that 120 range. Again, we're going to start with our total fluids of D10 with protein. We want to get a blood sugar. I always say that there's no point in getting a blood sugar before you have access, because what are you going to do about it? And an extremely low birth weight infant, we can't give them glucose gel. It's not approved for those small babies. So getting a blood sugar before you have a UVC probably isn't going to do much. So getting your UVC in, getting your blood sugar off your line also cuts down on your painful procedures, is going to, kind of help with this process. Then you might have your initial low blood sugar. Very common for your initial sugar to be low, especially if you've had difficulty placing the central line. I was just rereading the evidence about the golden hour admissions, and there are places that do start by just putting an IV in prior to starting their central lines. I tend to find that in the research more in hospitals that don't have dedicated central line nurses, so you don't always have someone to start on that line right away. If you have someone available, it cuts down on your painful procedures, your exposure, your infection risk, you're changing your fluids. It actually also cuts down in error if you just start with your central lines, because your fluids will be correct from the beginning. It's just something to think about, because it can make your blood sugar go low. We may have an initial low blood sugar, which we will treat with D10. A D10 bolus is going to be 2 mils per kilo, right? We talked about our normal saline or our LR bolus for our blood sugar, blood pressure, D10, blood pressure, normal saline or LR at 10 mils per kilo. Blood sugar, D10 bolus at 2 mils per kilo. Important thing to remember. Once the baby's admitted, you may see a spike in your sugar because of the stress that they are under. This rising cortisol level from the stress is going to affect your blood sugar. If your blood sugar remains low, instead of cranking up our fluids, we might actually need to crank up the dextrose. So typically we're going to start at D10 with trophamine, D10 with amino acids, whatever it might be. Then you're going to maybe go to D12, D15, go up from there. And it might actually be a balance where you start D15 and still run your D10 with trophamine or D10 with amino acids or starter TPN, whatever we call it, so that you kind of get to a D12 level so you can still have some protein going on there. Again, we're trying to reduce excessive fluids. For our late preterm baby, we might accept sugars down to 40. We can give them glucose gel, might get that in the nursery. They may actually come to us because of low blood sugars. We can start some feeding, or again, starting with D10. Some contributing factors for those late preterm infants include low glucose stores, increased glucose utilization, and then, of course, their poor suck, which leads to poor milk transfer. So in that first hour, not only do we want to make sure that we are getting our fluids going, getting our antibiotics going, but we want to think about what we're doing for neuroprotection. So there are tons of golden hour flowcharts out there. If your unit does not have one, this is a key to making sure that our communication is clear in that first hour. What our roles are, what's the nurse's job, what's the RT's job, what's the provider's job. How can we get pharmacy to get our antibiotics to us and our fluids to us if we have to order specialized fluids? But during that time, we also want to make sure that we're not lifting their legs up, that we're not doing major position changes. We actually have protocols in place where maybe we admit the baby in a certain position in case they're going to need to go on a high frequency ventilator so that we don't have to turn them again. During our first change of our linen, right? Maybe you got admitted in a poncho. It's time for the poncho to come out. It's time to get your polyurethane cover off. It's time to get your humidity going. With that first linen change is also when you're going to put your developmental positioning devices in so that we aren't doing a lot of lifting. Once you have that, you need to implement your neuroprotection care guidelines. Neuroprotective care guidelines, whether that's going to be for 72 or 96 hours. The evidence is kind of in between on both. It does lean more towards the 72 hours to reduce IVH is to do 72 hours of neuroprotection. So during that time, we want to make sure we're not having baths or weights. We don't want to put in a central line unless we absolutely have to. Kangaroo care should still be encouraged during this time. For our late preterm infants, of course, we want to minimize all of the handling and moving of them, but we do want to get them on skin to skin. We want to get the parents in there, and of course, having a calm and quiet environment, especially for our respiratory kids that really are in this TTN phase where we want to help them transition better. We want to make sure that we're providing them with that calm environment. This is a summary table. You know that the last few months have been my months of I'm in my table era, to quote my Taylor Swift. But really this idea of kind of the small differences between our ELBW infant and our late preterm infant. We're probably seeing a lot of admissions of both of these if you live in and work in an environment of a level 4 NICU where you're seeing small babies and kind of our late preterms either transferring down to us from mom baby or admitting directly. In general, we want to think about keeping them warm, getting their respiratory in control early and often. The major situation that you have with any sort of neuroprotection is when your CO2s get really high. If we have a major swing low, it's the same risk as having your blood pressure really low and going higher. We want to have gradual changes. So if we can start them, I often see providers starting our babies on CPAP of 6, even as opposed to 5, to try to get them into a safe place quicker. Again, with our glucose management, we want to make sure we have our dextrose infusing for our smallest babies, and then choosing between can we start feedings or dextrose in our late preterm infants. And of course, communicating with our parents, having them there. There are units I have seen recently in the literature where parents are even staying for the central line placement and just putting their hat and mask on like anybody else would, and so that they are still a part of this process from the beginning, which I think is super interesting and a great goal. I haven't seen it personally in practice, but I think it's an interesting thing that's out there in the evidence. What can we tell our parents during the golden hour, right? Tell them the importance of getting our lines in. Often our providers have either, if we know the baby's coming and it's extremely low birth weight infant, they've had a prenatal consult where they've kind of gone in and been like, in the first hour, we're going to have these goals of getting our lines started, getting our antibiotics started. Let's get consent now. So we already have it out of the way. Your baby may be intubated. We may be giving them surfactant. So the parents have this idea, but we know that not every mom walks into the hospital prepared to deliver her baby within an hour. So we may not have that opportunity. So we want to get them into our unit and then start explaining to them Okay, this is what we're going to do. We're going to be focusing on stabilizing your infant. Have the non-delivering parent come to the NICU so that they can see this is where your baby's room is going to be. This is the first things we're going to do. And then taking them back up during the central line placement. We want to tell them about touch hold, about the monitors. Who is this care team going to be? Do we have nurse practitioners in our unit? Are we a teaching hospital where we'll have medical residents? And then reviewing our goals of thermoregulation, fluids, blood pressure, blood sugar, neuroprotective care. So to recap, the golden hour is crucial for all babies, focusing on those immediate goals: thermoregulation, respiratory and cardiovascular support. An interesting thing about thermoregulation to think about too is not only do we want to get the top closed if you're using one of the Draeger incubators or they have all sorts of companies, the Giraffe, any of those incubators where they open and close, the Baby Leo, the Giraffe. Getting it closed and getting your humidity started within an hour is huge. Then you don't want to open the incubator unless you have to. Doing cares through the portholes, teaching parents how to do cares through the portholes, only opening the top, if you need to get out to do skin to skin, key, or a procedure. And explaining to the parents why we use the portholes, why we put the air shield on. All those things are super important. And then obviously, how can we get you pumping? What can we do for breastfeeding support? What is it going to look like when your baby's going to be here? What do the monitors look like? This effective communication, having golden hour checklists so that we know whose role it is to talk to the parents is going to be key. And what our ongoing plan will be past the golden hour. Thank you for joining me for this review. I hope this was helpful in kind of comparing these two things. Make sure that you are subscribed so you can see new videos as they post, and I will see you next week where we will do another redo of an August topic. Have a great Tuesday.